Dylan. I'm one of the junior doctors in Sheffield. Not had any formal training in neurology, so might not be able to answer all your questions at the end, but I'll try my best. I did a master's in clinical neurology, so that's why I'm doing this talk. So this is the second part of a two-part series. I thought I'd split it up into two parts, as neurology is quite a big topic, and it's really difficult to cover everything in 1 hour. And it is, some of it's quite complicated, so therefore I'll split it into two. So today we'll be covering head injuries. So I'll start off by talking about head injuries, and I'll go over like the neurophysiology behind head injuries, and then I'll talk about strokes, so mainly ischemic stroke, but we'll touch on hemorrhagic stroke, the confused patient and dementia, so a bit about delirium and dementia, and then just briefly I've got a few slides on headaches and some of the differentials for headaches. Again, there are a lot of things that I've not covered in my neurology talks, so feel free to go through them in your own time. It is massive. It's hard to cover everything. But yeah, so head injuries. So head injuries, so to start off with, to understand head injuries, managing head injuries, it's quite important to understand what we call this Monro-Kelly doctrine. So this theory, this basically says that the head is a closed compartment, and we've got a balance between brain volume, arterial volume, venous volume, and CSF. Now it's a closed compartment, so it's got a what we call intracranial pressure. Now, if there's an increase in any one of those things, we'll get a rise in intracranial pressure. However, there is compensation to prevent this rise in intracranial pressure, and therefore the compensation would be either venous return or CSF. Now, there's a bit of compliance here, and initially there is compliance, and the rise in intracranial pressure will increase venous return, increase CSF, and a rise in brain volume will increase venous blood flow, increase the loss of CSF, and therefore there won't be a rise in pressure. But eventually we lose this compliance, and there is a sudden sharp rise in pressure. So I'll just cover the background for this. So intracranial masses or brain volume could be any of these things. It could be brain, so it could be a tumor, it could be cerebral edema, it could be an abscess, it could be more blood. So they might have had a subarachnoid haemorrhage or intracerebral hematoma or an extradural. It could be a rise in CSF. So this could be down to increased production of CSF or obstruction in the CSF flow. Or it could be due to reduced absorption of CSF at the subarachnoid granulations. So Lauren was talking about this compliance, this compensation. So initially, if we look at the start of the curve, we have high compliance and this compensation. So increase in intracranial volume does not result in a raised intracranial pressure because we've got this compensation of venous return. We've got this compensation of CSF, losing CSF. So eventually, as the intracranial volume continues to increase, we get reduced compliance, and this compensation reserve gradually depletes. And we lose this compensation, and we get a sharp rise in intracranial pressure, and this increases risk of cerebral ischemia and herniation. So this is the curve. So how do we get this compensation? So compensation, to understand compensation, there are a few things we need to be able to understand. First thing is we'll call autoregulation. So autoregulation is basically we have change in the blood vessel size according to the cerebral perfusion. It's very similar to the autoregulation you get in the kidneys with the efferent and afferent arterioles, similar concept. So we've got, first of all, to understand, we've got the cerebral perfusion pressure. So cerebral perfusion pressure is made up of two things. So mean arterial pressure, take away the intracranial pressure. And that gives us our cerebral perfusion pressure, and that's what gives us our x-axis in this diagram. So the mean arterial pressure is actually the systolic blood pressure plus 2 times the diastolic blood pressure all divided by 3. That's our mean arterial pressure. Take away the intracranial pressure. And then we've got cerebral blood flow. Cerebral blood flow is the ratio between cerebral perfusion pressure and cerebral vascular resistance. Now, when we get this when we get a rise in cerebroperfusion pressure, we get a rise in cerebrovascular resistance. And this is why we get the narrowing of the blood vessels in the brain. And this maintains that cerebral blood flow. This is where we get the middle line. And then eventually, once we lose that ability to constrict the blood vessels, we eventually go off the curve, and we can get, if the cerebral perfusion pressure continues to increase, what we get is hyperperfusion, and we get edema of the brain, hyperemia, edema. And going to the back end of the curve, if you lose that autoregulation and cerebroperfusion pressure continues to decrease, then we get hypoperfusion ischemia. So this is what we call autoregulation. So autoregulation is trying to maintain the cerebral blood flow by changing the cerebrovascular resistance. So there are certain things that can increase cerebral blood flow. So increasing CO2, causes vasodilation, and therefore that can increase cerebral blood flow. And decreasing oxygen will cause vasodilation of the blood vessels in the brain, increase cerebral blood flow. So if we have a rising intracranial pressure, we go back, we want to maintain that cerebral blood flow. So we can do certain measures to maintain that intracranial pressure. And this could be hyperventilating the patient to reduce their CO2 to prevent that increased cerebral blood flow. We want to try and give them maintain hypertension to improve mean arterial pressure to make sure we don't get ischemia. We can sit the patient head up to improve the venous drainage, intubation to maintain ventilation, and also we can give them mannitol, which is an osmotic diuretic, to try and prevent that edema occurring. So these are all the measures we can take to prevent that rise in intracranial pressure. There are some surgical options as well, so we can do things like burr holes, put in external ventricular drainage, DVD, do craniectomy to take away a bit of the skull to let that brain swell, so it's no longer a closed compartment. And also there are methods of intracranial pressure monitoring as well that we can do in patients who've had head injuries. That could be putting an intracranial pressure bolt in the brain parenchyma, putting an external ventricular drain and seeing how much CSF is flowing through it. And also we can do transcranial Dopplers to look at intracranial vessels as well, to look at how they are autoregulating. So there are certain signs patients give away raised intracranial pressure. This can be, they can have a blown pupil, and this is down to because they can get a herniation. So as well as edema, they can get eventually get herniations of the brain, and a tentorial herniation, uncal herniation across the tentorium can compress the oculomotor nerve, and this is what gives us that blown pupil. You can also get compression of the cardiorespiratory center in the medulla oblongata against the foramen magnum, and this usually causes the Cushing's triad, which is decreased respiratory rate, which we call chain stop breathing, bradycardia, hypertension, and an increase in pulse pressure. The different types of herniations you can get in the brain. So you can get subfalcine herniation, which is across the I forgot the name of the membrane around the middle of the skull, brain, but yeah, the cingulate gyrus will herniate across. You can get transtentorial herniation. You can get uncal herniation, which classically causes the blown pupil. So, and you can get cerebellotonsillar herniations as well. So these are different types of herniation of the brain. And also you can use GCS to monitor any raised intracranial pressure, and it's quite important to understand GCS and be able to recall GCS on top of your head. So I remember I found it hard to put GCS to memory, but I remember it as eyes is a score out of 4. So minimum score you can get 3, the top score you can get 15. So eyes is out of 4 because you have people like me wear glasses, like 4 eyes, specky 4 eyes out of 4. And then motor is out of 6 because I remember it as M6, that motorway that runs across, so M6. So if eyes is out of 4 and motor's out of 6, then V is out of 5. So yeah, and then you just got to put it to memory. But yeah, that's GCS. So head injuries. So you can classify head injuries according to severity. So a minor head injury where the patient is GCS 8 to 15, or a major head injury where the GCS is 3 to 8. Also by the mechanism of injury. So is it a blunt injury? Is there penetrating injury? Is there depressed skull fractures? And the pathology of the injuries, is it a focal head injury or a diffuse head injury? Is there any skull fractures or intracranial lesions from head injury? And then primary versus secondary. So primary head injuries would be neurological damage due to the actual event. So this could be contusions, hematoma, diffuse axonal injuries. And then secondary head injury is subsequent insults because of the neurological damage. And this is things like cerebral edema, ischemia, infections because of the skull fractures, herniations. So these things happen later on, because primary is from the direct head injury. And then another type of head injury we'll call the coup versus counter-coup head injury. So let's say this person impacts the back of the head, you get contusions at the back of the head, that's the coup. And the counter-coup is because what we call, the theory is that the brain will move around in the head and there'll be a head injury, and as you see in image number 2 at the front of the skull, so the opposite side of the impact, and that's what we call the counter-coup injury. And then the other type of injury that I talk about is diffuse axonal injury. This is quite a severe head injury, and it's hard to see on a CT scan, this type of head injury. And this is because the brain's shaken in the skull, and this causes shearing of the axons and widespread damage to the axons in the cerebral hemisphere. In this case, we normally put intracranial pressure monitoring devices in to monitor intracranial pressures. And then we've got our classic bleeds. So we've got our subdural hematomas, which can be acute or chronic, and we've got your extradural hematomas. So just going over them. So extradural hematomas, so 10% of severe head injuries is bleeding outside the dura. As you can see, there's a picture. It's classically due to the middle meningeal artery. And they're bleeding because it's extradural, it doesn't cross the suture lines. And the classic symptoms are head injury with loss of consciousness, you get that lucid interval. Because it's an arterial injury, you get heavy arterial bleeding, and then suddenly the patient deteriorates because of the rising intracranial pressure. And this happens, you get that lucid interval because remember I was talking earlier about that compensatory phase. And the management of the extradural hematoma, again, you get symptoms of extradural hematoma should be hemiparesis, seizures, vomiting, Cushing's triad you can get, which is quite later on in the disease, blown pupil, and you need to stabilize the patient and transfer them to neurosurgery for difference in management, which might be a bell hole, drain out the extradural. Subdural hemorrhage, so this is again due to tearing of the bridging veins. Elderly patients are quite at risk of these because they've got an atrophied brain, so there's already a lot of pressure on these bridging veins. So it can be an acute thing. Again, it could be chronic in patients, elderly patients who've had a fall. So to tell the difference is because of the density in the CT scan. So in a chronic subdural, it's quite hypodense because you've got that part of the brain that's been liquefied, whereas in acute it's quite hyperdense, it's white on CT scan. And then you get isodense if it's subacute. So looking at the density of it will tell you whether it's a bleed or eventually the blood's been broken down and you get left with CSF then that's a hypodense chronic. And then subarachnoid hemorrhage, just to cover that, so it can be a traumatic subarachnoid hemorrhage, or you can have a rupture of a berry aneurysm at one of the points in circle of Willis, or atriovenous malformations can also cause subarachnoid hemorrhages. Classic symptom is sudden onset severe headache, photophobia. You can get raised ICP causing nausea, vomiting. The investigations you do under a CT scan or a CT angiogram. Lumbar puncture, again, it's usually better 12 hours after the headache if the CT is negative to look for xanthochromia. And then complications from subarachnoid hemorrhage can be ischemia from vasospasm. You can get hydrocephalus because you get the blood blocks off the arachnoid granulations, causing obstruction of the CSF flow, and hydrocephalus. Patients can get hyponatremia from syndrome of inappropriate ADH. Then you can also get seizures. And the management is coiling or clipping the aneurysm, and also AVMs. You can use gamma knife radiosurgery, and we use nimodipine to prevent that cerebral ischemia from vasospasm. So that's head injuries. So next, I'll cover strokes, ischemic strokes. So stroke, basically, definition of stroke is any acute neurological deficit from a vascular origin that lasts more than 24 hours or causes death. 85% of the strokes are ischemic. So the causes of strokes. So this is really useful grading classification system we call ASCOD. So ASCOD saying atherosclerosis can be a cause of stroke. This can be formation of a thrombus in one of the large arteries, either carotids or vertebral, which can then embolize the distal sites and block off one of the blood vessels and head. Small vessel disease, and this is from high age and hypertension causing lipohyalinosis. So I'll cover that later on, what that means. And this can cause lacunar infarcts. Cardiac pathology, so it could have, patients could have AF and MI, valvular endocarditis, which can form a clot in the heart. Any of these things will cause and fire off and cause a stroke. And then there's some other causes as well. So like antiphospholipid syndrome can cause venous strokes. So dural venous sinus thrombosis, sickle cell disease, vasculitis, these are all the causes of strokes. And also you can get dissections as well, causing strokes. So again, just to cover the small vessel disease. So again, hypertension, atherosclerosis causes that lipohyalinosis, and this results in the blood vessel can no longer dilate in response to the reduced cerebral blood flow. And then this can cause lacunar infarcts, which are basically infarcts in the basal ganglia internal capsules. And then you can also get watershed infarcts, which are basically watershed zones, which are regions between vascular territories. And if you get a sudden reduction in arterial blood pressure down from a cardiorespiratory arrest, anaphylactic shock, or major blood loss, then these areas are prone to watershed infarcts. So risk factors, again, age, hypertension, heart disease, high cholesterol, smoking, diabetes, peripheral vascular disease, previous TIA, clotting disorders, alcohol intake. These are classic risk factors of stroke, which you probably all be aware of. So you get anterior and posterior circulation strokes. So anterior is, if you look at the top image, anything stroke in any of the red regions. So middle subarachnoid, anterior subarachnoid territories. Posterior circulation strokes are strokes in the posterior cerebral artery, or any of the blood vessels coming off the basilar artery or the vertebral arteries. And that's the difference in anterior and posterior circulation strokes. Again, just to remind you of the blood supply of the brain, so you've got your middle cerebral artery, anterior cerebral artery, and posterior cerebral artery. So presentation, so this is the Bamford classification or Oxford classification strokes. So you've got total anterior circulation stroke. So like I say, total anterior, so anterior cerebral artery and middle cerebral artery. And then you can have a partial anterior circulation. So there's three symptoms. So there's unilateral weakness and or sensory deafness. Yep. Can you hear me? Yep. So total anterior circulation or partial would mean total is all three of these, partial is two of these, 2 out of 3 of these. So unilateral weakness or sensory deficit of the face, arm, leg, homonymous hemianopia, and higher cerebral dysfunction. So could have dysphasia, visuospatial disorders. And then you got your posterior circulation, and you only need one of these to meet the posterior, so POX. you've got TACs, PACs, and POCs. So that could be a cranial nerve palsy, contralateral motor sensory deficit, cerebellar dysfunction with the Danish symptoms, eye movement problems, isolated homogenous hemianopias. And then you've got last one is LAX, which is a lacunar stroke, which again, like I say, could be from small vessel disease, pure motor, pure sensory, or pure sensory and motor, or ataxic hemiparesis. And then one thing that you might come across is the Rosier to rule out. The Rosier basically is to rule out stroke in the emergency room. And this is a Rosier classification, similar to like we use the Wells score and things like that. This is more to rule out stroke in ED. So on examination, acutely patients will have hypotonia, flaccid paralysis, absent reflexes, even though it's an upper motor neuron lesion. However, later on, if we don't get proper rehab, then they can then present with the upper motor neuron signs later on. So, is there a question? So Moyamoya disease, not to worry about it too much. It's abnormal blood vessel formation in the head. Classically, it looks like a puff of smoke that they call in the head. It was one of the rare causes of strokes that I came across in my master's. Probably doesn't come up in medical school finals, but I'll let you read it up on it in your own time. But it's basically you get these abnormal blood vessel formations, which are high risk of bleeding because they're quite weak walls. Sorry, coming back. So upper motor neuron signs, yeah, later on they'll present upper motor neuron signs, so the clonus, the extensor plantar response, hyperreflexia. So let's go with dysphasia again. Just so you got Broca's dysphasia, which causes expressive non-fluent dysphasia, where the patients can't understand what is being said but struggles to express themselves. And then you got your Wernicke's, which is the receptive or fluent dysphasia, where what they're saying, they say fluent words, but again, it doesn't make sense. So you can't understand what is being said. Investigations. So first investigation, acute investigations, you want to do a CT, try and get a CT, non-contrast CT to rule out hemorrhage. Sometimes if it's one of the big blood vessel territories like the MCA, you might see the clot in the MCA in the middle cerebral artery. But yeah, just to rule out hemorrhage. You can do an ECG to look for any abnormal heart rhythms that might have caused the strokes for AF. And then blood's quite important. So your full blood count, UNE, lipid profile, so a thyroid function test, cholesterol, glucose. So certain things that might mimic strokes will be patients might be a bit anemic. Again, hypoglycemia. Clotting is quite important, and INR if on warfarin. And then investigations later on to consider. So if they've missed a time window for thrombolysis, then you might be thinking of doing a thrombectomy, in this case a mechanical thrombectomy, and therefore we might want to do a CT or an MR angiogram. Again, we might want to do a perfusion weighted MRI, which we'll cover in a bit. So perfusion weighted MRI again can be used to see how much salvageable brain there is for thrombectomy, or diffusion weighted MRI. If we're outside the thrombolysis or thrombectomy window, then a diffusion weighted MRI can actually confirm a stroke. But again, like I say, this ischemic stroke's hard to see on a CT early on. Carotid Dopplers later is quite important to do to see if the patient might need a carotid endarterectomy, and an echo of the heart to see if there's any other thrombus in the heart. So yeah, so perfusion weighted and diffusion weighted MRIs can show this. So you've got your ischemic core, and then you get this penumbra, which around the ischemic core, which is high risk of becoming part of this ischemic core. So just to understand that, so brain cell death. So you get perfusion failure, which causes brain cell death. You get, and this causes energy failure. So if there's not enough blood going out of the brain, you can't have energy to drive these sodium, potassium, HPA pumps. So therefore, the sodium then stays inside the cell, and this releases excitotoxic neurotransmitter glutamate. This causes a calcium influx into the cell, and this causes the cell to die. And then, because there's a lot of sodium in the cell, you can get water coming into the cell, and this can cause cerebral edema after a stroke, and this can raise the intracranial pressure. So this is why we get to that ischemic core, and then you get that penumbra around it, which is high risk of becoming from brain cells dying, high risk of the brain cells dying in that penumbra. And therefore, we can use these perfusion-weighted MRIs to see if there's that salvageable penumbra around that core for thrombectomies. So time is brain. So think about the management. So management, first of all, you A to E. So you treat any hypoxia or airway. You want to treat that. And then if they've presented within 4.5 hours of their symptom onset, and you've done the CT to rule out a hemorrhage, then you want to be thinking about thrombolysis. So you want to look at, see if patients got any contraindications of thrombolysis. There might be any recent surgery or anything like that. There's a whole list of things that you can look at in your own time for contraindications of thrombolysis. Again, if they've not within 4.5 hours, then you'd be thinking between 6 and 24 hours of symptom onset, it can be a candidate for a thrombectomy. Patients can have thrombolysis and a thrombectomy. But if the thrombolysis is contraindicated, they can just have thrombolysis is contraindicated, they can have just a thrombectomy. And therefore, we'll be thinking, is it worth doing a CT angiogram or an MR angiogram within 6 hours, or a perfusion MRI? Again, if the patient's got an unsafe swallow, then nail by mouth and NG tube. And if they've got signs of aspiration, then you want to try and do a chest X-ray and put them on antibiotics. You want to get aspirin 300 milligrams. Normally we continue 300 milligrams for 2 weeks and then switch them to 75. And then statin therapy normally starts 48 hours after. There's secondary prevention, so you can, like I say, secondary prevention will be clopidogrel or 75 milligrams of aspirin. And then primary prevention, someone who's had like a TIA or high risk of strokes, would be to reduce the risk factors, diabetes control, blood pressure control, statins. And then, like I say, anyone who's had a stroke will need MDT, so physio, occupational therapy, SALT team. So in terms of anticoagulation, if the patient did have undiagnosed AF and they had a stroke, you don't want to start anticoagulation, so warfarin or apixaban or one of the DOACs within 2 weeks because of this risk of hemorrhagic transformation. So, like I say, you can give them aspirin and then only start anticoagulation 2 weeks after. So you can start them clopidogrel and then you can switch them to anticoagulation after 2 weeks. And don't forget to do a CHAD-VASc and a Has-Bled score to see if they need anticoagulation. Question. Someone had a hemorrhage, stroke, and they had thrombolysis. Thanks for the question. A hemorrhage, stroke, and they had thrombolysis? You wouldn't thrombolyze someone who's had a hemorrhagic stroke. Okay, if someone had a ischemic stroke and they had thrombolysis, yeah, you'd want to give them aspirin. Like I say, you'd want to speak to the stroke registrar and see, you'd want to look and see if there's any contraindications and see if they've thrombolyzed them. They would advise you whether to give aspirin or not, but I think you would give them aspirin acutely, because I don't think giving aspirin will mean that they can no longer have thrombolysis. So you would give them aspirin, but you'd speak to the stroke registrar and you'd want to try and prioritize thrombolysis. 300 mils of aspirin for 2 weeks after, even if they had, we should still put them on 300 aspirin for 2 weeks after, even though you didn't give it acutely. If they had thrombolysis, I think you would still give them aspirin 300 milligrams after, as far as I'm aware. Again, that might not be right, but I think you would. And I've not heard of the Orbit score, sorry. I've heard of the Rosier score used in A&E, never heard of the Orbit score. And I've heard of the NIHSS score for strokes. But I've never heard of Orbit. Okay, so it's replaced has bled. Okay, thank you. Sorry, just to go back. So thrombolysis is within 4.5 hours of symptom onset. You can do thrombolysis once you ruled out hemorrhagic stroke on the CT. Thrombectomy would be between 6 to 24 hours. Again, you'd want to do a CT angiogram or an MR angiogram or perfusion MR to see how much salvageable brain there is before you do a thrombectomy. You can do thrombolysis and then a thrombectomy, as far as I'm aware. But again, like I say, some hospitals don't offer thrombectomy services out of hours, but you can do thrombolysis out of hours. So blood pressure. So again, you don't want to treat blood pressure unless it's above 185 acutely, or they've got any of these things. So hypertensive encephalopathy, hypertensive nephropathy, heart failure or an MI from the hypertension, aortic dissection, or eclampsia, pre-eclampsia or eclampsia. So unless you've got one of these, you don't want to acutely treat blood pressure. However, if the blood pressure is below 120, then you do want to stop any blood pressure medication. However, you should give about 2 weeks and then see if the blood will get the GP's review and then treat blood pressure, because normally blood pressure will normalize after 2 weeks. But acutely, don't treat blood pressure. And again, if you're looking after someone who's had a stroke, when would you want to repeat a CT? So again, because you get that edema, you'd want to look for any signs of raised ICP, so dropping GCS, if they're getting more severe headaches or nausea, vomiting, or if they've had a sudden increase in their blood pressure. Again, these large territory infarcts at high risk of edema causing raised ICP, so MCA territory, then you'd want to speak to neurosurgeons immediately to consider for craniectomy. And just a brief one on TIAs. So TIA is a brief period of cerebral ischemia. Symptoms usually resolve, last less than 24 hours. Amaurosis fugax is a TIA of the retinal blood supply because of monocular blindness. These patients are at high risk of strokes and heart attacks. So you'd want to refer that patient to the TIA clinic to be started on primary prevention. And driving, so after a TIA, you can't drive for 1 month, whereas after a stroke, you can't drive for 1 month. You must have had a recovery that allows safe driving. So that's everything. Okay. Sorry I couldn't answer all those questions. Like I say, I've not had any, not done any neurology jobs or not had any formal neurology training apart from a master's, which was, again, it was an intercalated master's, so don't have any detailed knowledge of strokes. And especially if things have changed now, because I did my master's 3 years ago. So confused patient. So confused patient. So just to cover dementia. Another question. So hemorrhagic transformations, basically, if they've had an ischemic stroke, they could bleed into that area of ischemia. And that's what we call it's transformed into a hemorrhagic stroke, or hemorrhagic transformation. So dementia is a loss of memory and a decline in high cognitive function. Types of dementia will be Alzheimer's disease, dementia with Lewy body, vascular dementia, frontotemporal dementia. So whenever you're thinking about this, you want to rule out other causes. Again, full blood count, urinary calcium, thyroid function test, B12, glucose. Rule out other causes such as UTI, alcohol withdrawal, polypharmacy, and again, you'd want to do a scan to look for any other causes such as normal pressure, hydrocephalus, or chronic subdurals. So history, so when you're taking a history of someone who's confused, you might get called to this on-call junior doctor presenting complaints of what has changed, what can they manage their current functional states. So in terms of mobility, getting dressed, showering, cooking, managing their finances, meals, how quick was the onset of this confusion? Sensory deficits, so speech, hearings, vision, and then any other signs of any infections anywhere, so urinary infections, chest infections, neural infections. And then had they had episodes like this before? Is it the first time they appeared like this? What was their function before they were coming into hospital? Past medical history, medication history, so again, like polypharmacy, and social history, so who do they live with, alcohol. So delirium is basically an acute confusional state, acute onset, and it fluctuates throughout the day. So you got 3 types. So you got your hyperactive delirium, so the restless, agitated, delusional, risk of self-harm, and hypoactive, whether lethargic, monosyllabic, and again, you can get a mixed type. So again, you start off with, you might want to stop any medications that might be exacerbating this. So classic ones are opioids, sedatives such as benzos, antidepressants, antipsychotics, antihistamines, acetylcholine blockers, correct any biochemical derangements, look for any source of infection that might be exacerbating the delirium, relieve any exacerbating factors such as constipation, dehydration, pain, urinary retention, sensory aids as well, so hearing aids, glasses. Try and keep the patient orientated in time with regular sleep cycles. Familiar ward staff, again, that's very difficult in this day and age. But these are sort of things you can work on to try and help someone's delirium. But again, delirium should not delay discharge. Patients can be delirious as long as it's safe to go home. Once they're back in their own environment, around familiar people, the delirium will settle over time. So just going over the dementias, so starting off with Alzheimer's disease. So most of Alzheimer's disease is sporadic. There is a small proportion of patients who can get genetic forms of Alzheimer's disease. This is a classic brain of someone with Alzheimer's disease. So you get this cerebral atrophy of the hippocampus. As this brain atrophy, ventricles become bigger, or appear bigger even. So they get 2 abnormalities in the brain, pathological abnormalities in the brain, someone with Alzheimer's disease. So we've got those ones, and then they get these plaques. So amyloid plaques. So the way these amyloid plaques appear is because we've got these enzymes. We've got amyloid precursor protein, which is a transmembrane protein. Now, normally you get alpha secretase and then gamma secretase, and the protein that's formed does not go and form plaques. Whereas in people with high risk, people with Alzheimer's disease, you get beta secretase, and you go down the right side of this diagram. So beta secretase, gamma secretase, and this forms this insoluble plaque, this protein, and therefore you get the amyloid plaques. Certain patients at high risk of getting these plaques, so someone with Down syndrome, because amyloid precursor protein is found on chromosome 21, they're at high risk. They get early onsets of Alzheimer's disease. You get mutations in proteins in these enzymes as well, and they can cause familial Alzheimer's disease. So this is how you get the amyloid plaques, beta plaques, and they get tau neurofibrillary tangles. So tau is basically a protein that helps in nerve conduction. It's usually unphosphorylated, wherever in Alzheimer's disease it's hyperphosphorylated, and therefore you get these neurofibrillary tangles of tau. The staging system used for Alzheimer's disease is the plaque staging. So you get pre-symptomatic, so mainly in the hippocampus, and then it moves on to involve more of the brain. So clinical presentation. So early you get episodic memory loss, so short-term memory loss, and then later on you get the more long-term memory loss, and then visual spatial problems, recognizing objects, faces, reasoning, so paying bills, shopping, problem solving, language problems, so word finding, verbal fluency. You can get psychiatric problems, and then later on they get the long-term memory loss. So I remember it as Alzheimer's is the A's, so apraxia, so problems with motor skills, agnosia, so recognizing things, and aphasia, so the language. And the main treatment of Alzheimer's disease is you can get donepezil, which is an acetylcholinesterase inhibitor, and NMDA, which is mentine, which is an NMDA antagonist. Next one's the Lewy body dementia. So what's the Lewy body? So if you were here at last week's talk, I talked about Lewy body. So Lewy body is this protein inclusion, and it's called Lewy body. It contains alpha synuclein. So it's found within the cytoplasm. So macroscopic features, they can get, again, like similar to Alzheimer's disease, so generalized atrophy, dilation of the ventricles, and then they can get pallor in the substantia nigra and locus coeruleus. So again, some of these patients have mixed Alzheimer's disease pathology. The staging is called, again, the BRAC staging, but here stage 1 starts off in the olfactory bulb and the medulla, and then it involves the pons, midbrain, entorhinal cortex, and amygdala. Whereas Alzheimer's disease starts off more in the hippocampus. Clinical presentation, again, it's similar to Alzheimer's disease, but the key thing in here is visual hallucinations. They get visual hallucinations in Lewy body dementia. They can later on develop Parkinsonism. They can get REM sleep behavior disorders where they act out with dreams, autonomic dysfunction. And again, these patients are sensitive to neuroleptics. So management, again, similar to Alzheimer's disease, and then you can use levodopa to treat Parkinson's and later on. And then you've got frontotemporal dementia, or Pick's disease, different types. So you've got your behavioural variant, where they initially start off with the personality change, but they have preserved memory and language and visual spatial skills. So they get disinhibition, emotional blunting, obsessive compulsive disorders, craving sweet food. And then you can get, so that mainly is when it involves the frontal lobes, so the inferior frontal lobes. And then you get the semantic version, which is problems with naming objects. You have awareness of this. So early on, they might have naming errors, calling a bus a car. Later on, using more general categories. So apart from saying bananas, apples, pears, they'll just say fruit. And then, oh, sorry, 1 second about that. About that. Later, and then advanced disease would be, again, loss of complete living and non-living concept. And then you've got your progressive non-fluent fluent aphasia. So difficulty pronouncing words, expressive language difficulties. And then this is associated with multineuron disease, because we've got overlap with the molecular pathology that we find in multineuron disease. So we get this TDP43 in multineuron disease, which is again found in frontotemporal dementia. And some frontotemporal dementia patients have multineuron disease features such as muscle weakness, hypertonia, hyperreflexia. And the final one is vascular dementia. So again, the risk factors similar to the ones we saw in strokes. And they get this stepwise progression, whereas the other dementia is not stepwise, this one's stepwise. And then just small vessel disease can cause this as well. So you get the arteriosclerosis, so the muscle The muscle, smooth muscle within the blood vessels get replaced with collagen or foam cells. That artery becomes very rigid and it can no longer respond to changes in blood pressure to maintain cerebral blood flow, and they'll get these lacunar infarcts. And there you go, that's the classic thing you'll see in vascular dementia. Again, a large vessel stroke can cause dementia if it's a large vessel stroke with the hippocampus. And the clinical presentation to get the sundowning, memory loss is less obvious than in Alzheimer's disease, but they get confusion, difficulty to pay attention and concentrate, reduced ability to organise thoughts or actions, unsteady gait, restlessness, agitation. So it's similar to the dementias, but the difference in this is you get sundowning and you get it stepwise, and the memory loss is less severe than in Alzheimer's disease. And then don't forget other things like normal pressure hydrocephalus, which causes dementia, gait disturbance, and urinary incontinence. And again, did an infectious diseases job. And again, don't forget you can do a HIV test on patients because HIV patients can get dementia, HIV-related dementia as well. And then look out for other things such as encephalitis. And then just quickly cover headaches. So 3: single acute headache, recurrent acute headache, and chronic headaches. So single acute onset headaches, so sort of things you want to be thinking about will be, is it meningitis, sinusitis? Is it a subarachnoid hemorrhage, carotid dissection? So also one of the bleeds. Again, don't forget giant cell arteritis can cause a temporal headache, but there'll be non-pulsatile tender temporal arteries. They can get jaw claudication, visual symptoms, and they'll have a raised ESR. And again, hydrocephalus can cause an acute onset headache, vomiting, impaired consciousness, papilledema. So it's quite important when you think of acute onset headache to rule these things out. Recurrent acute headaches, so again, trigeminal neuralgia, cluster headaches, migraines, so headaches lasting 4 to 72 hours. They'll have an aura, so visual aura, photophobia, and then the management will be triptans and NSAIDs, and then prophylaxis we can use things like topiramate, which is anti-epileptic, and propranolol. And then chronic, so chronic headaches, more than 15 days a month of headache. These can be from medication overuse headaches, tension headaches. And again, chronic headaches, don't forget to rule out or ask these red flag questions of space-occupying lesions. So headache that wakes them up at night, worse in the morning, made worse by coughing or sneezing. Fundoscopy to look for any papilledema, ask for any focal neurology symptoms.